at the WA Syphilis Outbreak Response page. So just be a reminder, what you say and what you type in the chat will be memorialised on the internet forever. So just be aware of what you're saying. Just general kind of housekeeping rules around, please keep your mic muted unless you want to ask a question. Lydia has asked that we will save all questions to the end, please. So if you've got any questions, maybe write it down somewhere so you don't forget. We can ask Lydia at the end and have that discussion there. Yeah, otherwise we shouldn't take more than an hour, but we'll see how we go in terms of Lydia's presentation and also discussions afterward. But I will pass it now on to Dr. Donna Mack to kind of open the session, and we'll go from there. Thanks, everyone.
Thank you, Stephen, and thanks everyone for coming, and thanks Lydia for doing this presentation for us. We thought it would be a really good idea to ask Lydia to present at the monthly Syphilis Lunch and Learn, because the work that she's going to talk to us about is a really good example of how we can use routinely collected data to drive quality improvement, and not just that, but to bring a whole group of stakeholders along with us in that journey of quality improvement. So I won't say any more and steal Lydia's thunder, but we're really happy that you're here with us today, and very grateful the work that you have done in in the health service with all the stakeholders that you've engaged in this project. So thanks, Lydia.
Thanks so much for having me present. And so I'm a RMO based in Geraldton with the WA Country Health Service. Before I get started, I'd like to acknowledge the Southern Yamatji people, who are the traditional owners of the land on which I stand on today. And I'd like to pay my respect to elders past, present and emerging. So I'll start off by outlining the problem, followed by some context to the project and the Midwest. And then I'll give you an outline of the audit, the root issues and the solutions identified. So the main problem that we identified is that only 30% of women were reported to have complete syphilis testing in the Stork database, and Geraldton had the lowest rates compared to similarly sized WACS sites. So Stork is a database that's used by midwives in public health, public hospitals, to enter all sorts of birth data. And this data then feeds through into the midwives notification system and shows up on the maternity dashboard, which can be found here. And this is what the maternity dashboard looks like. It's a really good resource that includes data on syphilis testing, other things like C-sections and stillbirths and many other things. So a bit more about the project. So this project was part of the Clinical Service Improvement Program done through the WA Institute for Health Leadership, and the program encourages nursing, midwifery, allied health, medical staff to take part in a service improvement project using the DMAIC model. So this is an evidence-based model which has been around since the 80s and was initially used by Motorola, but it involves the stages: define, measure, analyze, improve, and control. Okay, so as per the King, Edward and Silver Book guidelines, we test 3 times in pregnancy in the Midwest, and these tests should be done at the first antenatal visit, at 28 weeks and at 36 weeks. So there are many models that exist to ensure continuity of care for a woman during their pregnancy. And in the Midwest, we have shared care between GP obstetricians and the midwives at the hospital. Aboriginal patients who attend the Geraldton Regional Aboriginal Medical Service, so GRAMS, have access to a GPO and a midwife on site. And in Geraldton, GPOs see their obstetric patients from their GP practices, and this allows them to keep servicing Geraldton with the extended scope of GP rather than just being limited to GPO. So as part of the CSI or the DMAIC process that I talked about earlier, it's really important to take into consideration the voice of the patient, staff, and the organisation. These were some comments that were noted by patients, including the benefit of opportunistic testing, the other priorities taking over when it comes to antenatal care, like parenting or managing big families, the importance of using jargon-free language, and also the role that socioeconomic status has. So the challenges that were raised by staff included the presence of multiple lab providers, copies not being sent to the hospital, inconsistent use of the national handheld record, and the transient nature of some of the patients that are in the Midwest. So the WACS values and the health department's Your Safety in Our Hands report was taken into consideration. And this reinforced the importance of integrated services and good communication so that we can provide safe care to our patients. So the overall aim of the service improvement project was to improve the reported antenatal syphilis testing rates and hopefully other antenatal testing rates as well. So moving on to the audit aspect. So an audit was used to assess the issues in the process, and the audit included women who birthed either at the regional or at St John of God as a public patient between November and December last year. And participants were included if they had been booked into the antenatal clinic at least once. And syphilis testing was used as a marker for, I guess, what is happening with the other antenatal tests as well. And the audit looked at actual testing rates, which was represented by these sources here, and compared them to what was entered into the STORK database. So there was 86 participants, and the mean age was 29, and it ranged from 18 to 42. 30% of participants identified as being Aboriginal, 12% identified as being culturally and linguistically diverse. And here is the distribution of parity, the births and gravity pregnancies. So this graph shows the models of care, with the majority of people being managed by a GPO, with the midwives at the regional or at Grams. And you can see here that the majority of the public patients were delivered at the regional, and that's what we would expect. This image here shows the people who received antenatal care with another healthcare provider. So, for example, 2 were managed in Carnarvon with the maternity service there and the Geraldton service. So you can see that we're doing really well before 28 weeks. So for the first antenatal visit syphilis test, 95% of women got a syphilis test before 28 weeks. But for the 28 and the 36-week tests, we're not doing so well. Just under half are reported to have got tested at the correct time. And the main thing that this graph illustrates is that many people actually got the test, but it was done early. And the other main thing to note here is that there's a proportion of people who have no evidence of testing, or have had other tests, but not the syphilis test. And it's quite a similar observation late in pregnancy as well. So you can see in these graphs here, in this graph here, that most of the early 28-week bloods were being done between 25 and 28 weeks. And when speaking to GPOs about this, this is exactly what they expected, as they tell their patients to get their 28-week bloods done just before their 28-week checkup, so it can be discussed. Or the GPOs often request it with the glucose tolerance test, which is done between 24 and 28 weeks. And here's the data for the third syphilis test, which should be done at 36 weeks. And you can see that most of them are getting done in the 1 week before. So the main thing, so moving on to the communication of results. So the main thing that this pie chart illustrates is the proportion of tests that were not copied to the maternity department. And you can see here in the shades of yellow. And an audit of the forms, the pathology request forms, shows that about 15% of tests did not have copy to Geraldton Regional Maternity on them. And in about 10% of tests, the pathology service Y was not following through with the copy to, and pathology service X was sending results to an unmonitored inbox that we can't seem to find at the regional. So it turns out that CCing is a manual process at service Y and was being overlooked by employees. And once again, quite a similar observation late in pregnancy. So this table shows the issues with data entry. There are false yeses, false nos, and many are entered as unknown. You can be fairly confident that results entered into Stork are sensitive, but it's not very specific, and there's a low positive predictive value. And these are the parameters for the 36-week test. So in addition to the audit, a staff survey was sent out to, I guess, further characterize the issues in the process. And I don't expect you to be able to see the font, but the communication breakdown between primary care and the maternity department has resulted in an increased workload for clerical and midwifery staff. So clerical staff receive results in up to 3 forms of results, and they search for results in up to 6 places. Midwifery staff look for results in up to 6 places, with 3 of these places already searched for by clerical staff. And there are multiple errors, as we've discussed, with the data entry into Stork. And I think that one of the likely issues is the difficulties with finding test results and that contributing to that. Okay, so we realised from this audit that syphilis testing is part of a much broader issue, and the audit helped us to identify that there are so many levels and healthcare providers involved in this process, and there's key issues at each level. And so those key issues or challenges are at the level of the patient, low socioeconomic status, transient populations, and reduced health literacy. The lack of a clear referral or communication procedure with the hospital, copy to being written in the wrong place, copy twos being a manual process at the pathology provider, an unmonitored inbox with results getting sent to. There was a checklist being used by the clerical staff that was not up to date, and it didn't reflect the current antenatal shared antenatal care guidelines, and they were looking for results that were not routine. And it was clear that there was need for a formalised internal clinic procedure relating to results. So at the level of the midwifery staff, there was no allocated clinical preparation time or data entry time, and staff were doing this in their unpaid overtime. And Stork responsibility was everyone's responsibility. but I guess making it difficult for it to be one person's job. And then there has been a bit of a fall off in the data entry training into Stork in recent times in Geraldton. At the level of the IT systems and HSS, we have lots of agency midwifery staff, and there is often delayed access to clinical apps and Stork, making it very tricky. And finally, the data dictionary or the date cutoffs don't seem to really reflect what's happening in actual practice. So to ensure adherence and implementation of solutions, we need to think in the long term, and all of the solutions implemented are taking into consideration the following points. So we're currently using the application best practice in Geraldton, but that's going to be ceased in later this year. And a digital medical record will be rolled out hopefully later this year. And another thing to bear in mind is working towards a greater or the widespread use of My Health Record, and eventually also the central referral service, which will be rolled out in due course. So one of the core issues that we talked about in one of the previous slides is that there was lack of clear expectations outlined to primary care providers on what to include in a referral or a booking letter, and as well as how to share results with the regional. This is a new protocol that we're implementing. It's starting here. You can see this outlines what happens in the earlier visits and how to upload the results. This outlines what should be included in the GP practice template. And here we can see that we're now formalising a 35-week summary or an update from the GPOs to the midwives, and this is now expected for all patients. It also, this guideline also outlines some of the nuances of different computer applications that were also some reasons why syphilis test wasn't getting entered into the practice template. For example, best practice operates off the national guidelines, so it only has a spot for one syphilis test at the beginning of pregnancy. So some GPs were entering this into the diabetes section manually or just finding a different spot to enter it. So this is the revised checklist, and it only includes the routine investigations. It's up to date with the current care schedule, and it also encourages accountability by having tick boxes. So also, I understand you probably can't see the font, but this is the original process. So red is the medical steps, blue is clerical, and green midwifery. And it's up to 20 steps to get one syphilis test into the Stork database. And so this is the new internal protocol, and we've reduced the process by 7 steps. And I only highlight the important points, but it involves clerical staff commencing the checklist early on in the process. It involves collecting results from one source, so calling GP practices for missing results, rather than looking at multiple secondary sources, which is up to 6, as we talked about earlier. It also encourages opportunistic testing. So, for example, if a patient presents for their antenatal clinic appointment and they are missing a test, or they haven't got their tests, we can call the phlebotomist down to the clinic, or we can encourage the patient to go to the testing service, or we can add on the missing blood test, and informing the GP that this has been done. So closing the loop and educating GPs in the long run. And you can also see here that this is the 35-week update that we just talked about as well. So I've gone through 3 of the 13 solutions that I've implemented or are planned for implementation. However, there's many more. I won't go through all of them now, but some recommendations moving forward that I haven't been able to implement in the span of an 11-week project, but they include looking at incentivising antenatal care for low socioeconomic patients, improving the user interface of My Health Record for clinicians so that we increase the uptake, and then increasing the uptake of the My Health Record app on patients' phones, which I just got yesterday, I didn't know about, and possibly electronic option for the National Pregnancy Handheld Record, with results that can be accessed remotely, or linked in with the My Health Record. And finally, altering the data definitions in STORK to reflect actual practice. And also time allocated into the clinical midwife roster for clinical preparation. So I've learnt so much in this process, and the most important takeaways from this program for me have been the importance of listening to the voice of staff, patients, and the organisation, involving stakeholders throughout the process, and always ensuring that solutions are sustainable with long-term goals. And so that concludes my presentation. These are all the people that I would like to thank so much for all their support and for teaching me all the things that I learnt this term. So any questions?
Thanks, Lydia. Yeah, please, people feel free to use the raise hand function or pop something in the chat. Oh, Marissa, I see you've got your hand up first.
Yeah, so has Deanna. So anyway, congratulations, that's excellent, well done. A lot of work obviously went into it and a lot of thought, and great presentation, nice and clear. Thank you very much, very good. I had one question which I'm sure is going to be a really stupid one because I must have missed something. In the time the audit was done, can you refresh me about how many months that was done over? Because it looked like it was only one and a half months, but that can't be right. Or is it?
Yeah, so it was two months. So all of November and all of December in 2023, and that was 86 births.
Right. So people who would have their tests, it's just a snapshot then, it's okay. And then is there a plan? Well, one question is, I imagine that the whole process kind of raised raised the awareness. Do you think that might have had an impact in general in what might happen going forward in terms of passion for getting it done despite all the errors? And is there going to be a repeat, planned in a year, or I don't know how long it's going to take to fulfill all those recommendations? Is that on the agenda?
Yeah, so with regards to your first point, yeah, it definitely has raised a lot of awareness. And actually, I was on night shift last night on the ward, and I was speaking with one of the midwives who I had a bit to do with during the process, and she had just created this new orientation for new agency midwives, and it's a treasure hunt, so it's quite sweet. But it involves looking at where the point of care testing station is for syphilis, and she was really proud of that change. And there's been some self-driven changes after the completion of my project as well that I haven't really initiated. So it's been really nice. And then the second point with regards to following up the data, yeah, there is definitely a plan to re-audit. And we've got a good medical education unit here at the moment, and we've got like an audit register. So this is going to be put on the register, and there's always medical students and RMOs who are keen to do audits. So hopefully that will be an easy one to pick, given it's already set up, ready to go.
Great, thank you. And I'm sure that it's been presented back to the exec and things like that locally, I imagine.
Yes, it's been fed back, yes. Thank you.
All right, and then we have Deanna.
Thanks, Stephen. Hi, Lydia. How are you? I'm Deanna. I work in Central Office for Public Health, and in my role, the syphilis stuff centrally falls under my umbrella. So it's not so much a question as a comment that expect an email, because I do want to pick your brain further in terms of how this might extrapolate beyond the Midwest into other regions. And because one of the things we're looking at doing over the next couple of years is how we can make some system level changes to embed this, in particular, this priority area better. And so, yeah, expect an email in the next couple of hours. But I want to introduce myself, so it's not just a random email from some person called Deanna.
Yeah, don't worry, I'll respond.
Thanks, Lydia.
Yeah.
And well done for stringing coherent sentences together after night shift.
No worries. Thank you.
And then I think it was Maddie was next.
Hi. Sorry if I missed this. Was there any consideration? So if someone was born or had the baby earlier than like the 34, 36 weeks, was that captured? Or if they were like, you know, they'd come from a different place from South Australia, say, you know, later in their pregnancy, so it sort of stuffs up our plan.
Yeah. So as it is reflected in the dashboard as well, but births are excluded. Sorry, the testing is excluded if a patient delivers before that time point. So that was reflected in the data. And then we didn't actually have anyone that had come from over east. We only had those few patients, I think, in that map that I showed a bit earlier on, where there was another healthcare provider that also provided a service in addition to the Geraldton maternity unit, but we didn't include anyone who didn't receive any any ongoing antenatal care through the Midwest. But I think we managed to include everyone anyhow in that time point.
Thank you.
Please, anyone else, if you've got any other questions, please raise your hand or use the chat function. I suppose my question, Lydia, first, great job on this audit. It looks amazing. Would you be happy to share, I suppose, the processes further with any public health units who would be interested in doing a version of this or a copy and paste of your audit? Would that be okay?
Yeah, from my point of view, yes. I'm not sure who else needs to okay that, but yeah, from me, yeah.
Cool. Does anyone else have any comments or question for Lydia while we've got her on the screen?
Feel free to email me if you need to.
Is there anything from you, Yoli, because I know I've done some work on this, or Donna, if you want to say anything maybe as we close this up?
Yeah, thanks, Stephen. So in terms of the repeat audit or any queries about replicating this audit in other regions, please approach me, because I'm the clinical lead and can ensure that going forward once Lydia has moved on. She's already moved on, in fact, from this CSI role. So thank you, Lydia, for making time when you're in the middle of night shifts on a completely different job. It's much appreciated. Yeah, so please just come to us if you've got any questions. We're more than happy to share, because there's a lot of very valuable learning from this project. And even outside of the scope of antenatal testing and syphilis, there's a lot of very useful learning just around quality improvement and approaches that people should try to keep in mind with that. Congratulations, Lydia. Very good work you've done. Very good presentation. I think it's probably also worth commenting, and I would hand over to Donna to comment on this, that some of the other recommendations that we will see going forward are going to be implemented, for example, through the pathology working group. So that's something Donna can comment on. Other bigger picture recommendations, I would really welcome a discussion around that perhaps today, such as that data dictionary and STORK. I think that would be a very valuable discussion if we wanted to kick that off now as well. And also, if we can look to the fact that our guidelines are different to the national guidelines, just how we can get a WA jurisdictional implementation of some of those recommendations with, for example, all of the different GP software providers. And I think that's sort of bigger picture stuff, but that's what this group is here to discuss today. Thank you.
Thanks very much, Lydia, and thanks, Yoli. I'll just speak to some of the points that you raised. So the pathology working group, and especially the private laboratories, have already said that they have I think the customer liaison officers who are very happy to work with individual private general practices to get certain things programmed into their clinical software. So my recommendation for that is perhaps to let the GPs in your area know that this service is available, and if they're using a private pathology provider, they literally just need to pick up the phone and ask for help to do this. They will program it in. At the national level, the updated syphilis song is doing its rounds yet again, and there is certainly a lot of support to increase the testing to 3 tests nationally. So I can't promise if it will happen or when it will happen, but there is a lot of move towards that. And so I suspect it will happen at some stage, but I think in the interim, get the GPs to be working with their private pathology providers. In terms of the data dictionary, would be really useful to find out whether that practice of doing the tests, a week or 2 weeks before is more generalized across the state before we change the data dictionary. But if we do find that it is, then I think that's definitely something that can be done. And I think we have got reps from the midwife notification system, the data custodian, and we might also have a laboratory person on the video conference. So if you're there, would be really good if you wanted to make some comment or responses to Lydia's audit.
I had a look, Donna, and I didn't see anyone from Maureen's team or any pathology providers in the room. They were invited to come today.
Yeah, because they said they were coming.
Yeah, I had a quick scan as Lydia was speaking because I wanted to see who's in the room.
Yeah.
Unless their job title was different to what I didn't see anyone. So if I'm incorrect, please, pathology providers or someone from Maureen's team, please put your hand up. So I don't want to misrepresent you.
Do we have any pathology providers with us?
Donna, I'm Sudha from ACL.
Oh, hi, Sudha.
Yes. I haven't been able to attend your pathology group because I was away on leave, but hopefully the next one in July.
Mm-hmm. And Sudha, from ACL's point of view, because I know that the ACL provides quite a lot of private pathology to Geraldton for the GPs, are you happy if the GPs call the customer liaison officers and get some help to program the syphilis testing into best practice or whatever software that they're using?
Oh, definitely, yes. Do I need to find more information for you on anything, or do you have everyone? Do you have the customer liaison person and everything else that's needed?
I might hand over to Yoli or Lydia for that.
Any leads would be most welcome. Thank you.
Okay, sure. I'll find out and let you all know. Thank you.
And Lydia, I know that you've deliberately de-identified the laboratories, but perhaps if necessary, you could make contact with Sudha if that manual CCing process is something that ACL needs to think about.
Right. Hopefully we are not the laboratory Y or X or whatever they were. But if not, let us know. Definitely we can fix the process and work on it.
Well, thanks very much.
Any other questions or thoughts or commentary for Lydia and her work, but also Yoli or Donna Mac while we're here?
I could try to lure some other comments. I'm aware that some GPs have done their own audits, and if any of you are online and would like to comment, that would be great. And I'm also aware that one of the other regional public health units did a small audit on syphilis testing in their antenatal population. And I can see that one of your public health nurses is here. So if you'd like to share any of the learnings that you also picked up in your audits, that'd be great as well. And if not, fair enough. Yeah, I think also the so to replicate an audit of this scale, so Marisa, you did pick up that it sounded like a very small window, only 2 months, but the amount of work that goes into actually collecting all of the pathology results, reviewing the clinical record for every single birth of the 86, just in that small 2-month window when they're on 2 sites, because they birth at both the regional hospital and some of the public patients are birthing at a private hospital, and also collating all of the relevant GP midwife records. So yeah, even for a data set of what on the surface sounds quite small, that's just the tip of the iceberg in terms of the amount of data that needs to be collected and then analysed. So if anybody is looking to replicate a similar audit to try and do some troubleshooting around your processes, yeah, I would recommend that you just do a quick scan first to look at the number of births that you would be analysing, noting the huge size of such a data set.
Thanks, Yoli.
Maybe, yeah, I mean, I might also comment that we were all surprised by the number of steps in the small, what we all think is a very small journey. Someone needs a syphilis test and someone needs to know the result of that test. And if you look at that blue, green and red flow chart that Lydia put together, I think we would all be very surprised to see that, to see just how many steps that one little test has to get through for the right person to see the result and for the right person to have done it. So, it can't be overlooked how complex it is. And so obviously we've got all this new software that's going to be coming, and thanks Lydia for sharing that, the timeline and BOSNet when they come online, and that will vary for different regions. So I know our wheat belt, we've already got some of that rolling out now. So I think it's important to reflect on that and knowing that we're all looking at the maternity dashboard data, but these are some of the gaps in that data.
All right, thank you. I think
I was just wondering, sorry, with that in mind, because there was an awful lot of information you shared actually, Lydia, and it was quite quick, to see some of those tables and take it all in. What process can we have, obviously respecting it's your presentation, to look at some of those charts in particular that would be good to have another look at? I mean, noting that it's obviously Midwest, it's Midwest information, and maybe that's not that relevant, but I don't know. It is quite interesting, but not critical, like you say, because it's relevant to your area and you're sharing it with the people there, I'm sure, as you said. So don't worry, ignore me.
Yoli, do you know much about the sharing of the results? Are you able to comment on that?
Yeah. I mean, it depends who's asking, because we've got a wide audience on today's meeting, some of whom are not WA Health staff. So it really depends who wants to know what. Certainly within WACS, we've got a bit more leeway in terms of sharing our data. So yeah, like I said earlier, if anybody is interested, just send an email to myself and Lydia and we can deal with your request. Thank you.
Thanks, Yoli. If there is no more kind of comments or questions for Lydia or Yoli or Donna about the audit and its findings, we might wrap it up there. Thank you so much again, Lydia, for presenting, particularly after night shift. You did a great job on a Friday lunchtime as well. It was great. And thank you, Yoli and Donna, for supporting Lydia in this as well. It was really, really great. Please, I'm sure if anyone doesn't have Lydia's email, I'm happy to email me. I'll put you in contact with Lydia or Yoli or Donna if you would like it, don't have it already. Thank you so much, everyone, for attending. I hope you have a lovely rest of your day.
Thank you.
Thank you. See ya.